Thank you everyone for being here the first day in a crowded room, Wednesday morning, and thank you for the kind introduction. So, as we've seen, psoriasis symptoms may change according to intensity of lesions, subtype of psoriasis, it's not the same PPG that plague psoriasis, and as well, site of involvement. Regarding nail psoriasis, we would all agree that patients with severe nail dystrophy, onychodystrophy, such as like this one, will struggle with daily life activities such as wearing socks, shoes, or engaging in sports activities. However, we have patients there that they do not have these impressive nail changes, but they still suffer from a lot of pain. And I'd like to illustrate this with a case. This is a 59-year-old woman with no family history of psoriasis or psoriatic arthritis that she came out to consultation complaining of painful and very, very sensitive nail changes for the past 3 years. She had a lot of stigma. She was not showing her fingernails like this in the consultation until we asked her to. And she had been treated by her local dermatologist with topical clobetasol varnish for 6 months with no improvement at all, and for 2 years with methotrexate up to 17.5 milligrams weekly without almost no improvement in the nail psoriasis. On physical examination, we can see, and I'm sure all of you have seen these patients that have limited psoriasis in terms of BSA, because here we can see only a patch on the elbow and intertriginous involvement. And regarding fingernails, she had only 3 fingernails involved, but she had all the fingernails in her feet. However, the only ones that were painful were the ones in her hands. Her DLQI at that moment was of 4, which is not that high. And, well, if we have a closer look, well, we can see that there's onycholysis and salmon patch, but what's more impressive for me, it was that they were really painful. When you palpated them or just touched them or just any subtle touch was very painful on her nails. So in our workout, we performed X-rays, which were normal. The acute phase reactant CRP, ECR were in the normal range. However, I thought, okay, maybe it's not only nail psoriasis. We all know that nail psoriasis is really related to enthesopathy. So I asked our room colleagues to see her, but they couldn't find any signs of PSA or signs of enthesopathy on ultrasound or psoriatic arthritis. We have an ultrasound in our department, so we perform nail ultrasound, and as you can see here, we can see a high Doppler signal on the nail bed or the nail matrix, but no signs of enthesopathy. So even though according to the just numbers, the LQI, PASI, he was not, as we would say, completely eligible for biologics in our country. We started with adalimumab biosimilar, which is the one we start with according to local regulations, and she had complete response after 6 months. So we all have seen patients with nail psoriasis, and up to 80% of patients with psoriasis may have nail changes during their lifetime, but we have to remember that pain is reported in up to 50-60% of patients. Ultrasound of the nail matrix, the nail bed or the lamina, we can see their abnormalities, and it is true that they are more frequent in patients with enthesopathy or PSA, but they are not exclusive, as well as higher Doppler signal. And regarding DLQI, it might be limited. In fact, if you have a look at the questions, they ask only about skin, and that's why that's what the patient told me when I asked her about, okay, your DLQI is only of 4. What we have in the literature, we have a look at this systematic review with the reporting outcomes in randomized clinical trials on nail psoriasis. Almost all of them have used NAPSI, but regarding patient-reported outcomes, all of them used DLQI, but very few used specific index. What we have out there, there are several prompts, but the most used are NPQ10 and NAPA-QOL. The first one is short, it's very brief, it takes a few minutes, and it focuses on manual activities and functionality. It was validated in almost 800 patients, but only in France, and the validation is limited to other languages. On the other hand, we have NAPA-QOL, which is longer. It has three dimensions, physical, stigma, and daily life. However, it is longer, but it's validated in other languages. So it would be more suitable for clinical trials, while NPQ10 would be more suitable for daily life. And just to sum up, and I think I've adjusted to the 6 minutes, so we might have some time at the end of the session. We have to remember nail psoriasis burden is often underestimated, even for us, especially pain and stigma. Nail ultrasound may be helpful to see this inflammation on the nail bed, nail matrix, and as well to rule out enthesopathy or PSA, and that's something that maybe more rooms will do. The LQI does not fully capture nail impact, and for that we have nail-specific patient-reported outcomes. Thank you very much.